Okay, guys, so portal hypertension, let's talk about that first. It's a major complication for cirrhosis. So the portal veins with the cirrhotic liver become narrowed and scarred. This in itself restricts the blood flow to the liver. So that would restrict the arterial blood flow to the liver, not allowing it to have some nice rich oxygenated blood to try to heal itself. And then we have high pressure that occurs in the portal system itself. So the portal veins, the superior mesenteric and the inferior mesenteric veins, pressure occurs because there's nowhere for the fluids to go into the liver because of its damage. The increased pressure in these portal veins then gives it the name portal hypertension. The stomach, intestine, spleen, pancreas veins all merge into that portal vein, and that increases the pressure in these organs. So if we have high pressure in this portal vein system, and it's not being able to go into the liver itself because of the damage, then it's going to back up into these organs. So you're going to get splenomegaly, which is an enlargement of the spleen. The pancreas is going to become enlarged, the gallbladder, and so on. These large distended veins as well are called varices. So you've heard the term esophageal varices, which we'll talk about shortly. But the varices are basically a bulging of the vein. It bulges out, and that causes it to be weak, and then it can easily burst. And when you have a burst varices, then you have GI bleeding. And depending on where the GI bleed is, where that vein bursts, will depend on whether or not we can help the patient. Like we said in the previous slides, they also have a problem with their clotting factors. So their fibrin and their vitamin K. And so that adds to the increased risk of bleeding if a varices actually does burst, which does happen. So with portal hypertension, like I said before, one of the complications to portal hypertension, which is a complication of cirrhosis, is esophageal varices. So here is the esophagus right here. And those varices are very susceptible to rupture. The veins are very dilated and bloated, and so they're very, very weak and easy. We just spoke about this. So some things we can do to kind of decrease that pressure so that those varices are not bulging out so much is we can give them beta blockers. So a beta blocker, what it does is it decreases basically the heart rate and the blood pressure. So if it decreases the blood pressure and the heart rate, then you're going to get less dilation and less aggravation of those varices. You're going to read also about octreotide. So octreotide is great. We give it as an IV piggyback. This is a secondary label for octreotide, but what it does is it vasopresses the hepatic areas, so that the hepatic veins, so that they can decrease their bleeding. So if someone has a very high risk of bleeding with their liver values, we can, let's say they're fluid overload, and we need to really pay attention to decreasing their fluid volume overload, to decrease that pressure, to decrease the varices. We can also give them octreotide to decrease the risk of bleeding. So it constricts those esophageal and proximal gastric veins and decreases also the portal hypertension. In turn, it decreases the portal hypertension. And then, of course, diuretics. So we want to try and get that fluid off, but we spoke about albumin. So giving this patient diuretics alone is not really going to do that much. But if we give them albumin or some type of hypertonic solution to draw that fluid out, then they can urinate the fluid out, and that in turn would decrease the varices. There are other mechanical things that they can, the physicians can do to help with the varices, and that will learn in a med search. So another thing that becomes enlarged due to this increase in pressure is the spleen, and that is splenomegaly. The spleen is kind of interesting. It stores platelets and WBCs, really. It's kind of a backup storage unit. So if this is enlarged and has increased pressure in it, then there's really no outlet for those platelets and WBCs to go into our circulating system. So in turn, we have decreased platelets and WBCs. Which again, if you think about the problems that, think about what we spoke about before, what the liver does and what the problems occur because of liver damage, then you can see how we really need platelets because of the bleeding issues that we have. And we really should have our circulating WBCs because of the increased fluid that is stagnant now in our body, able to get bacteria buildup, and that high risk of peritonitis if some of these organs might burst. Ascites. So we talked about ascites and the fluid. Here I want to show you on this picture. This is a great picture actually, and you don't see this all the time, but these are the engorged hepatic veins that you can see on top of this patient's acidic belly. The fluid accumulates in the abdomen due to damage due to that portal vein. They have low albumin, remember? And so this is where the fluid goes. It's not in the right place. And this fluid can also leak into the blood and into the abdomen. Bacterial peritonitis can occur. You can see that with all this fluid in here, there is a risk of bacteria forming in there. Typically it's E. coli, strep, or staph. E. coli is in our body already. Actually, all of these are in our body already, but you don't want to have them in the peritoneal cavity. Let me see here. We talked about ascites, fluid to the bloodstream. So treatment for this is going to be either a paracentesis. So this here is a drain that the patient can use at home. So they can drain their abdomen, their ascites, with education from the physician by themselves at home. And they would obviously, when they have flare-ups of this extra fluid, because sometimes it's there all the time, but a lot of times it goes down and then it comes up, then it goes down and then it comes up. So you can really be at risk for this. And so we want to give them antibiotics prophylactically as well. And as you can see with our conversations about antibiotics, this is also a problem because then they can easily become resistant. And these, when they do the paracentesis, this is a direct portal into the peritoneal cavity. And so this in itself could cause bacteria to go into the peritoneal cavity. So some treatments for cirrhosis are antibiotics to reduce that intestinal flora, the bag stuff anyway. I'm just going to go over the meds here, really. The lactulose to reduce ammonia. So we need to know our ammonia levels, monitor that every day, monitor our patient for any signs of mental incapacity due to possibly hepatic encephalopathy. The ammonia comes out via our stool. It attaches to the lactulose, but we can also give it PO or through an enema. Our beta blockers, that will decrease our venous pressure and hopefully decrease the chances of our varices from rupturing. However, remember I said that the liver patient will often have peripheral hypotension. Their pressure is in their abdomen. It's in other places. It's not where it should be. So we need to monitor their blood pressure really closely before we give these, because these will decrease blood pressure. Octreotide is often given as an IV piggyback for those specific patients that their labs show that they are really at high risk of bleeding. And so the last thing we want is for varices to rupture and for them to hemorrhage. Vasopressins that constrict, again, the esophageal and proximal gastric veins to also decrease that portal hypertension. And then diuretics to get off the extra fluid, again, monitoring their blood pressure, but also knowing that, you know, we need to move that fluid into their vein prior to giving the diuretics, and that would be through albumin. Oops, let's do that again. Oh, okay, albumin. Let's just do this. Albumin. And the albumin is given IV piggyback. Actually, no, sorry, it's on a primary line. Sorry about that. It's not a piggyback, it's a primary line. And it's in a glass bottle. So you really have to monitor it because it's really slow to drip, even when you're using a pump. And you need to make sure that it all gets in there. We will have one last video